now Dr. Ananth is already there. He's going to be talking about his triphobic experience with triphobic lenses. Over to you, Dr. Sir.
Yeah. Thank you. Sushil, can I share my screen?
Yes, sure. Go ahead.
Yes. Hope you can see my screens.
Yes, we can. Yes, we can.
Yeah. So good evening, everyone again. And first of all, I would like to thank all AIOC and Argal sir and Ratish, our IOC team, for giving me this opportunity to speak upon this topic, my trifocals, with my experience with trifocals, the two triphobic. See, as Dr. Kamal was telling, there is inhibition from majority of the practicing phaco surgeons to promote the patients for the multifocals and the trifocals. Maybe the reason behind this, they have misunderstood and they are not able to understand the optical design and the surgical expertise. That could be one of the reasons. Looking to my good volume of accredited, people wanted me to start trifocals, and in my talk, I'm going to discuss in a way that how the young surgeons can literally understand the lens, the optics of the lens, and how to proceed. The complete experience, what I went through over the last 1 year, I will be sharing it. Already a lot of physics has been explained by Dr. Pankaj, the previous speaker. Normally, we know the young patients, non-cataractous crystalline lens, how good the accommodation is, how good the depth of focus and the amplitude of focus is there in these patients, because of which they are able to see the vision at varying distances. The good quality of vision in a non-cataract patient is very well maintained because of good contrast, which in turn is controlled by the chromatic aberrations and the sphericity of the cornea. And aberrations are also very important in this. But the same patients, when they become older, once they develop the cataract, they do expect the same amount of quality of vision post-surgery also. We as a surgeons should be ready. That's what I believe in. Same IOL will not fit everyone. It's a personalized approach. The lifestyle has changed, and especially post-corona, the intermediate vision has become a big entity. People's expectations are very, very high. We surgeons need to understand and learn what and all options we have to offer to the patients. We need to give what they want, and we need to understand what they are. To do that, we need to understand that each and every lens, focal point, and ranges has to be understood by the surgeon for the better lens selection. And there are so many options to treat presbyopia. To have a very good Snellen's happy patient, good quality, and good contrast, there are only few options. I feel trifocal is one of them. Multifocals are already in line, but still, why do we need trifocals? Whatever the technology develops, multifocals, intermediate vision is an issue. As I told, post-corona, intermediate vision has become an issue. Each and every patient, the economy is improved. People are having smartphones. They are using their laptops and the mobiles more. Intermediate has become an issue. And glares and halos are issue with multifocals. And contrast is an issue with multifocals. To overcome all these things, the trifocal plays a role. The optics are much more better than multifocal in trifocals. EDOF are also in the same line. But for the last 2 years, we can see EDOF lenses, there is a compromised near vision. And whenever the range of focus is increased, dysphotopsic symptoms are very minimal in the bright light. But in my practice, I could see with wide variety of EDOF lenses, dysphotopsias are there in the dim light. That becomes a bad remark for these EDOF lenses. We need to overcome these two things, a good near vision and a good range of focus where the trifocals come into light. So coming on to the same IOL selection criteria, it's very, very important. Just like any prescription correcting IOL, you should select a patient who is desirous to reduce the dependence on the glasses. You should be able to explain him, you should be able to choose the lenses. You should not try to convince him. That never becomes a happy patient. Mild degrees of astigmatism is always suitable. And whenever I correct this prefer presbyopic IOLs, I prefer not to take this very elderly and the patients with against the rule because their depth of focus is already pretty good. I don't want to disturb it. But in that way, I will try to adjust in my biometric, which is another discussion itself. Hyperopics are ideal, and a patient who is ready to deal with mild amount of reduction in contrast and discomfort of symptoms, yes, we are ready to take them up. Say no to trifocals if the patient needs to be convinced very much, who is having unrealistic demands, severe dry eye, oblique astigmatism more than 20 to 30 degrees, and post-treatment pathologies which can affect macula and optic nerve, better not to take. Next, coming on to my choice of trifocal IOL triphobic. The optics of this IOL completely impressed me. I think much of Pankaj has already discussed the physics of it. Let me tell you how I could understand and what message I can give to the young budding surgeons. We all know about the asphericity of the lens. Asphericity is very, very important for a good quality of vision and a good contrast vision. And these triphobic lenses are negative aspheric lenses, which has got a value of around minus 1.5. Whenever we have a good aspheric surface for any IOLs, the contrast improves, a better mesopic vision, and it is the lens of choice for all the young patients. And this triphobic has got a aspheric anterior surface. Second property which impressed me is apparitization. It is nothing but how the height of the ridges reduces from center to periphery. This technology is very, very much required for appropriate distribution of the lights. If you see in trifocal, as I mentioned, this optic has got a central addition of plus 3.5 and a peripheral of 1.8. Both these ridges are apodized. If you look into the competitive trifocals, those multifocals are apodized, but their trifocals are not apodized. This helps for the equal distribution of light to the focal points. Third one, we all know these guys makes square head technology. It prevents the PCO protection, which is very, very, very important. And when under the lab condition, because of the super patent optic design, they could see the optical transmission quality is very good with this material. Again, the same thing the previous speaker has mentioned about the dynamic energy transfer. It's and the lab test they have done. And this is very, very important. This is one of the things objective measure to expect the vision at a different distances. I do not do it in my clinical practice, but when they tested in the lab condition, they could see that the defocus curve for this IOL lens was very good for the intermediate vision, which we could clinically see in my patients. Contrast sensitivity. This is one more important thing which has been involved in this optic we need to understand. Any hydrophobic material will always contribute to this chromatic aberrations. And hydrophobicity, if we have to make a higher power lenses, the thickness increases. But even in spite of not increasing the thickness, the diameter of the refractive zone has not been reduced in these lenses. If it has been hydrophilic, we may have to reduce the thickness. We may reduce the thickness by reducing the optical zone. But here, the refractive optical zone is not compromised, but the thickness has been reduced. So that's why this has got a superior optic quality. And already MTS has been mentioned by him. And in my clinical experience, I have done around 60 patients of 30 eyes, and almost majority were women in this, the age group around 55 to 65 years. And to my results, I could see the patients had literally very good uncorrected visual acuity. And the intermediate vision, we checked at 60 meters, and with their arm length also, I could make sure that they were very comfortable using their smartphones or their mobile phones. There were no complaints, and near vision was never an issue. We almost all the time we targeted emetropia based on their pre-existing refractive error plus or minus 0.25. We corrected. And coming on to the quality of the vision, we could ask the questionnaire telling them about what they're literally bothered, because glares, halos, starbursts, these are the terminologies which are present on the Google. I don't think even in my LASIK experience, people come and tell about the glare, halo, starbursts. I feel they're just created. I want to tell what they're dissatisfied. Was the light bright? Was the light dim? Was they difficult to driving? These was the questions I asked them. But majority of the times they felt didn't bother them. So, and spectacle independence, they have enjoyed till now with my 1 year of follow-up. Added to all these things, a good surgeon should always do a CCC of 5.5. His surgical astigmatism should be minimal. Good cortical cleanup, IOL in the back, thorough visco wash, Biometry is very, very important. If possible, rely upon good biometrics. I use my IOL7 master. So to conclude, I feel that trifocal implantation can be performed by any cataract surgeon who is aware of the principles of refractive surgery and handlessly precise, who knows about IOL calculation. Triphobic in my hands, it gave an excellent functional vision at distance, intermediate and near in my clinical practice. And all the patients have enjoyed the spectacle independence after triphobic implantation. Thank you.
Wonderful, Dr. Ananth. I couldn't agree more with you. And I think one thing which in the preoperative probably skipped your presentation was you have to rule out a surface disorder.
True.
Because, you know, patients with bad corneal surface, a dry eye tends to be, as it is, they're little unsatisfied patients.
Yeah.
The keratometries can go haywire. And if you take them up for multifocal or a trifocal technology, IOL, without treating their surface disorder, they could be kind of a little bit unhappy. So that's at least my observation. So I always do a dry eye evaluation. We do a dry eye mapping. In case they're dry eye patient, we treat that first, and then we take the patient ahead. So I think one observation from even your presentation is that how after using a particular lens, your concepts which have been drilled into your head about glares, halos, starburst are all slowly going away. They're flowing away.
Yeah, they're going away.
You're not seeing them in your own patients. So I think it's more of our fear, which we say, keep asking the patient, are you seeing a halo?
Yeah.
Are you seeing a glare?
Yeah,
so a lot of times he needs to think and say, okay, Dr. Ananth, if you're seeing, maybe, yeah, I think I see glares. So it's like forcing it down the patient's throat. I remember we had a LASIK patient, initially in the counseling, the plates for the LASIK machine, they had a lot of vacuum. So they would create a red mark. So I would tell the patient, you will have a red eye after surgery. In case it happens, don't worry. So I suddenly realized my patient's parents would call up, Dr. Kapoor, I hope the surgery went fine. I said, yeah. But my daughter doesn't have a red eye. So they were expecting a red eye because I was telling them, and if the red eye was not there, they thought that the surgery has gone wrong. So it is our inhibition which is trickling onto the patient. And if you're not talking much about glares and halos, I think with this particular technology, glares and halos is something which you